The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
I was never famous for being able to stand in the same place for 20 minutes, so this is going to be a nice challenge. And I'm here to talk about something which is the complete opposite of low-hanging fruit or an easy solution, but it is a good way of improving identification, early identification of the deteriorating patient in the non-acute care areas, better gathering information, and hopefully simplifying decision-making when it comes to these complex patients. And I'm talking about the electronic medical record that was launched by the Royal Children's Hospital a bit more than a year ago now. It was developed with the American software company Epic. And please bear in mind that everything I'm going to show you in the next 20 minutes is protected by copyright laws. It is, I'm told, the first fully integrated EMR system in Australia. It means it has some features that are very useful, both to the critical care areas, but also to the non-critical care areas. So, as I said, it was launched a bit more than a year ago, and in one day, the whole quaternary hospital confirmed from paper-based hospital to a non-paper-based hospital, and 4,000 staff members had to do everything on the EMR. And it went from all to none, and it including everything: admissions, notes, prescription, administration of medication, ordering x-rays, ordering CT, ordering theater periods. It was a bit of a mess. So you can imagine how much went into the training and education of the staff. It was over 30% of the budget, and the budget was almost $50 million. And we had 4 stages: the familiarization stage, where all 4,000 staff members had to sit courses, workshop, simulation that had to do with what do you do with the EMR while you're treating your patients. Some were mandatory, some were non-mandatory. All of the staff members had to sit a basic exam showing they can function basically on EMR. Next step was go live. That was the 30th of April 2016. And by this day, there was an overwhelming number of supportive people, both from Epic and from North America, and allocated people that got extra training, super users among the staff members that helped everyone. Then the almost business as usual era, and now we're in the business as usual era. So now let's go back to talk about the deteriorating patient. So in the Royal Children's Hospital, we have 3 different levels to provide care in the non-critical areas. There's the PQ outreach, which is a very proactive system where a dedicated outreach nurse and an ICU reg are going to see patients around the hospital. They can get referral from any medical staff member, from ED, from theater, but from wards as well, and they also follow up discharges from the ICU. Rapid reviews are being done in our hospital by the ward team if the patient is stable enough, and medical emergency team always are a dedicated ICU nurse and a dedicated ICU reg. During daytime, it's also a dedicated outreach nurse. And they respond to every medical emergency. We don't have code blues. So in theory, every med call might be a code blue and deteriorate to CPR. In the EMR system, there are features that help us treat, identify, and gather information regarding these sicker patients. So this is the Victor chart, and the Victor chart is essentially an observation chart which is statewide, and it was launched before Epic and was just translated from paper to the EMR. And as you can see, we have here observation of saturation, respiratory rate, work of breathing, heart rate, and each of these have a different distinct three colors. So white is normal, and then orange is outside the normal zone and needs more frequent observation and air review. The level of review depends on how sick the child looks. And then there's the red zone that essentially requires a MET call unless there was a MET modification. So unless the patient has been proved to be stable with an abnormal observation for that age group. The Victor charts are age group dependent, so this is a 1 to 5-year-old chart. Because it's on an EMR platform, we can change the time frame from 1 hourly to 24 hourly and everything in the meantime to have better understanding of what we're treating and to have better auditing and root analysis of abnormal events. This is the other half of the Victor chart, blood pressure, temperature, and what you see at the bottom is essentially a summary of everything I so far showed you in the Victor chart. And as you can see, some of the numbers are in red. That's a good way to alert the nurse that is putting the numbers in that it's abnormal and something should be done. This is the escalation of care pathway of the Royal Children's Hospital. Again, it talks about the same orange and red zones of the Victor chart. So the orange zone, if the patient is stable, it still requires increased observation ratio, calling someone more senior to have a look at the child, either the ANUM or the ward team. If the child is unstable or these two other options did not resolve the problem, then a MET should be called. Once again, things to improve patient safety, things to increase the early identification of a sicker patient. This patient that I'm showing its screen has oxygen desaturation, so the system will alert the nurse that there's desaturation and a rapid review or MET are required. It also shows the nurse that there's been a MET Victor change of modification of threshold. So this patient is known to have an observation abnormality and it was already changed in the past. It also looks at other demographic features of the patient, and for example here shows that there's very high risk of pressure injury. So it doesn't only show you abnormalities, it preemptively shows you these are high-risk patients, and over time we'll be able to identify more and more high-risk patient groups. There's nothing more frustrating than to come to a CPR scenario and not to come if the patient is for rhesus or not for rhesus and who's actually in charge of this patient. And again, you have the details of the patient, you have the emergency contact of the patient. All our patients need their parents to approve things for obvious reasons. You have the rhesus status of the patient. You have the care team. So if your hospital have 3 different surgical teams, you don't have to chase the notes to understand who's the actual surgeons who looks after that patient, and you know if there's any exotic infection that was identified in the past. So now let's describe what the EMR or the EPIC at the Royal Children's can do to the deteriorating patient, and we'll do it as a scenario in less than 10 minutes. So this is our young patient. His name is Thomas. I carefully tried to look for a pathology that adult intensivists will understand. So he had a mitral valve repair. Okay, he didn't have any exotic Fontan surgery. He was in ICU for 2 days and discharged to the cardiology ward on day 3. He is on not a lot of oxygen. There's still chest drains and pacing wires in situ, so pain is an issue. So he is on ongoing morphine infusion. This is a low dose for those of you who don't do pediatrics, and some Panadol. Heparin is a routine thing we put through all our central lines, simply because our central lines tend to be smaller, hence easier to clot and block. And Lasix because no one ever went through cardiology ward without getting Lasix. At day 4 post-op, there is a MET call from the cardiology ward for increased work of breathing and desaturation. When I'm coming to a med call, or when I used to come to a med call, now I'm staying in the ward and sending someone else, it's very easy for me to go there, assess the patient, hear the problem, and then via Epic, having a very quickly gathering of information without having to look at 4 different systems on the computer to find the data I need. So the fluid balance for the last 24 hours and for the whole admission and potentially for the last hour or the last 4 hours is very easily accessible. So are all the previous bloods and all the monitoring that can come up on a dedicated screen. If there are monitors you don't need, you can take them off if you just want to see the correlation between ICP and blood pressure. It's very easy to access the X-ray as well, ordering it through the Epic and seeing it on the Epic and naturally seeing the report on the Epic as well. And this is our Met Navigator, which is how we document every Met call now. It's composed of both smart text boxes and free text area. It's a combination of clinical data and data that we know will be used in the future for auditing and research. The Met Navigator is smart, so it will automatically absorb data from previous notes of the patient to give me the history of the patient. It will automatically draw the observation from the monitor, so if the patient is being monitored, and all our post-op cardiac patients will be monitored in the cardiac ward, it will give me the 4 last observation sessions. And then all I, as the doctor, need to write down is the recommendation. So in Thomas's case, we gave him some oxygen, we gave him some Lasix. He looked much better. We organized an emergency transthoracic echo by the cardiology fellow, and we said he's safe to stay in the ward. Advantages of our Met Navigator: it's a very clear communication tool. No one is going to complain about the fact no one prescribed anything, no one charted anything, and there's no plan, because you have to write a plan as part of your Met Navigator. It improves reporting, it improves auditing, it will improve research when we start doing that, and it forces data entry because you have to press at least one box in every area. The disadvantages: it's being filled by the ICU reg of the day. Not all of them have the same level of compliance and enthusiasm as others, and it did require quite a lot of education due to that. Okay, so this is Thomas, and 1 hour later, there's another med call for severe desaturation, bradycardia, and hypotension. And quite quickly, this time, we're getting into a CPR scenario. So all our scribing during CPR is now on a resus narrator, which is again part of Epic. And the resus narrator can start as a rapid intervention, or it can start as resus, and the rapid intervention can be converted to resus. So you don't have to make up a decision and then to live to regret it. It started only in the critical care areas, ICU, and emergency department, but we loved it so much, we started using it not only for CPRs and acute deterioration, we are using it for semi-elective procedures, replacement of an ETT, closing chest in the ICU, which is something routinely that we do in the pediatric intensive care. It's a very useful platform because unlike the piece of paper scribe, it allows you a clear timeline. It forces you to put data and observation in, so it's not lost. The piece of paper won't be lost because it was put on the computer in the first place. It has very easy access to all the potential procedures you're doing. It has access to inpatient summary, and it's integrated in the system on the same time. This is our resus narrator. A is the area of one-step medication. So I will say I want adrenaline based on the weight of the patient. The system will automatically calculate a resus dose of adrenaline, 10 mics per kilo, and the nurse will see it on the screen, will give me the 10 mics of adrenaline. I don't need to allocate a medical person to scribe the drugs that I'm giving. And the computer is assisting me with the right dosing. That left side is activities. Have we started CPR? Have we started chest compression? Have we tubed the patient? B is event log, times for everything. C is patient summary, so it's very easy to go back to all the patient's data. And D is order sets such as blood transfusion. So at the end, what you get is a list of cardiac arrest started, compression started, all with timing, ETT placed, ETT assessed. Okay? There's no what actually happened during this CPR scenario, as we all know and love from the past. Big advantages, no gaps in data, there's forced data entry, it frees the medical staff, as I said, there's no drugs missing data, and as we said, there's one-step medication process. The disadvantages, you must allocate a very experienced nurse to do the scribing, so it takes one of the most experienced people to the side to be there with the computer on wheels. You won't let someone who doesn't know what to expect to run that show. Again, there's a large computer on wheels in the room. I don't know if how many recess scenarios you've been in the past. The room is very crowded already. And the one-step medication process is potentially risky. In the last 12 months or so, we have started to allow the cardiology ward to use that resource narrator, so not just ICU and ED. And this was post a very traumatic medical that deteriorated to CPR, that deteriorated to ECPR, the child crash on ECMO and PQ, and at the end, no one actually understood what happened during the hour of CPR because the scribe just disappeared. It took a lot of effort of training a non-critical care nurse to operate the resource narrator in the cardiac unit. There was a lot of theoretical Q's and A's and exams. They had quite a lot of simulation on the mock patient in the EMR. They did real-time simulation using EMR as the scribe. They did a special exam on the resource drug calculator to make sure they're not just giving us the wrong dose, and they went to go through an exam of accreditation. 1 year later, 92% of all medicals in the cardiology ward are being run by the resource narrator and not a scribe. All the nurses are happy. The medical wards and NICU are asking for support to implement that. So what are we going to aim for in the future? We want to have better monitoring of all high-risk patients. We want to get to the point the system will know to identify them and potentially send us and the ward team an alert, maybe to our ESCOMs, maybe to our pagers, saying, be careful about that patient. And to summarize, this is a very sophisticated, high-tech system that will potentially allow us to improve detection and treatment of high-risk patients that deteriorate outside the critical care areas. Thank you very much.